Welcome, everyone. We'll start in just a moment. Just letting a few people sign in. It looks like we've got a really nice attendance list here, so welcome to all of you. I won't call you all by name. So we're going to get started at 6 o'clock, and I appreciate those of you getting here on time. My name is Alan Kaplan. I'm a family physician in Aurora, and I'm the regional primary care lead at Central Region. And I have the distinct pleasure of introducing Dr. Lackman, who's an obstetrician gynecologist at Oak Valley. For those of you that don't know where Oak Valley is, is Markham Stouffville. Everything's name has changed. Fortunately, our names are still the same, Felice. That's good.
Yeah,
So we're going to update on HPV, which is a tremendously exciting topic that we have to learn because it's a new paradigm. It's a new paradigm how you're going to approach cervical cancer screening. And Felicia's a perfect person to do this. She's got an unbelievable passion for cervical cancer screening. Has really taught me a lot in our few years working together so far. In terms of how this is going to go, the talk will be given. We have a question and answer box at the top, so you can put in your questions there. We have some interactive things. So if you use the chat to sort of throw your answers into the chat, that would be perfect. This is approved by the College of Family Physicians of Ontario for Main Pro credits. It's up to 2 credits, so I think we'll be here for like about an hour and a half or so, depending on how many questions there are. So maybe even a little longer, maybe 2. So you can apply for up to 2 credits for this. And unfortunately, you're going to have to do the evaluation survey at the end of the session. It's provided for you in order to get the credits sent over to you to then be done. So I really look forward to learning from Dr. Lackman today, and I'll pass it over to you.
Thank you so much, Alan. I'm really excited to be talking to everybody about HPV implementation because this is the first time I've been able to actually talk to you about it when it's actually coming. So in 1 month from now, March 3rd, we are go live and it's really exciting. I'm going to start sharing my screen and I just need a verification from someone that
Not yet.
the screen. Okay, hang on, it's coming.
We're supposed to have music in this little interlude. So.
Yeah. No, nothing yet?
Nope.
Okay, hang on. Share entire screen. Choose a screen. Oh no.
So while she's fighting with technology, I'll just throw in here that the important facet to take away from this is that we're no longer testing the pap smear in the cells. We're now actually looking for the HPV virus, and that guides what we're going to do. So that's probably the key change that you really have to understand the difference of it. And it'll make a lot of sense when Felice expands upon that. There we go. Good job.
Yes.
We're there. Yeah.
Okay, great.
Yeah.
All right.
No, make it full
Yep,
screen,
yep,
and there we
yep.
go. Perfect.
It's coming.
All right, you're all there.
Okay. All right. So welcome everybody. Of course, I can't see anybody. I can only see my slides. So it's like talking to a computer screen, but I know you're all there. So like I said, I'm really excited to be talking to you about this today. I want to make this practical. I want to make it useful. There's a lot to go through. So let's get started. Please take a moment to acknowledge the land that you're on. This is the land acknowledgement for Toronto, where I currently am, but I know everybody's in a different spot. I hope everybody is safe and sound at home. Please sit back, relax, pour yourself a glass of wine if you like, and we're going to start off. I have no relationships with financial sponsors to disclose. I am the regional lead, so I am employed by the Regional Cancer Program. So our agenda for today includes a whole bunch of things. There's going to be a little quiz at the beginning. I'm going to give a little bit of an overview of HPV and cervical cancer. We're going to talk about HPV testing, cervical screening terminology, the new screening recommendations. Changes to the practice is going to be the meat of the talk. So this is going to be where we're going to focus. We're going to talk a little bit about what's going to happen in colposcopy. We're going to talk about what happens when they come back to you after colposcopy. We're going to touch on vaginal vault testing and some case studies at the end. And I will do my best to answer all the questions that you have. If you can please put questions in the question and answer. And if I can't get to them by the end of the meeting, I will certainly look at them and email you back with answers. So we're going to start with a little quiz, and all you need to do is either think about your answer or put your answer into the chat box. You're not getting marked on this, okay? So fill in the blank. Approximately blank of sexually active people will have at least one HPV infection in their lifetime. 50%, 80%, 60%, or 20%. So I'll give you a second to think about that one. And then, as you guys know from previous talks, 80% of people will have at least one HPV infection in their lifetime. It's extremely common, and it's common because it's an infection that happens just from contact, genital contact, so that condoms are not protective from this virus. Question 2, true or false? Almost all cervical cancers are caused by persistent infection with oncogenic types of HPV. Take a second to remember that this is true. Almost all of these cancers are caused by a persistent infection. Question 3, it typically takes blank for persistent infections with oncogenic types of HPV to develop into cervical cancer. Less than 6 months, 1 to 5 years, 5 to 10 years, and 15 to 20 years. So again, it takes a very long time for these infections to cause cervical cancer, 15 to 20 years. And that is why cervical cancer is almost 100% preventable, because it takes so long for these changes to happen that we can pick them up before they turn into cancer. Alan, if you could just tell me quickly, can you see my face and my screen? Like if I hold something up, you can see it?
I can see your face, I can see your pointer, and I can see the screen.
Perfect. Okay, great. All right, so let's talk a little bit about HPV and cervical cancer. I don't want to spend the bulk of the time on this because we've talked about this a lot in the past, but like we said, HPV infections are common. 80% of sexually active people will have at least one HPV infection in their lifetime. There are over 100 types of HPV, and 13 of these types are the high-risk types or the oncogenic types. And specifically, number 16, 18, and 45 are of particular concern, and we will talk a little bit more about those in the coming slides. Persistent infection with oncogenic types of HPV is the main cause of cervical cancer. So it's not a transient infection, which most of them are. It has to be persistent, ongoing infection. You guys have seen this slide before, and this just shows the natural history of cervical cancer. So you go from normal cervical tissue, which gets infected with HPV. This may cause some low-grade changes, but if the immune system is able to fight off this infection, these low-grade changes may resolve on their own back to normal. If the infection is persistent, these low-grade changes can become high-grade changes or precancerous changes and eventually turn into cancer. But again, it takes 15 to 20 years for this to happen, and we can pick up the infection now with the HPV test even before it causes any trouble. We can pick up low-grade changes, we can pick up high-grade changes, and hopefully we never have to pick up cancer because we catch it before and deal with it. So what this slide is showing is the natural history of HPV clearance. So what you can see is these are different types of oncogenic HPV, and as time goes on, most of these infections will clear. So by the 2-year mark, almost 90% of infections are clear. So what this shows is by 2 years, almost 90%, 3 years, we're up to 90% of these infections will clear over time. 5% of the infections will persist, and only 3% of these infections will progress to cervical precancer or cancer. So the bulk of our patients, even though they're going to have an HPV infection, will clear this infection on their own. What this slide is showing is the risk of progression by HPV type. So up here you can see HPV 16 and 33. So these are the most likely types to progress to cervical cancer. The reason we don't talk about number 33 very much is because it's quite rare. It only comprises about 1.9% of all HPV infections, where HPV 16 comprises about 26% of HPV infections. So even though 33 has a high risk of progression, in terms of disease burden, it actually doesn't cause that much. And that's why it's grouped in with the other types of HPV, high risk types, as opposed to 16 and 18 and 45, which are specifically noted on the HPV positive test. You can see that 18 and 45 actually have a lower progression than 16 and 33, but they are worth noting because these are the HPV types that contribute the most to adenocarcinoma. So that is why 16, 18, and 45 are going to be the ones that are specifically pointed out on your HPV results, and then the other oncogenic types will be grouped as one. So it's really important for us to understand the HPV test. And why are we moving from an HPV test, from a cytology test to an HPV test? So from this, you can see that HPV has a much higher sensitivity, 96%, than cytology alone, which is our PAP, only 53%, okay? We do know, though, it has a lower specificity. So a cytology test is much better at telling us who has the abnormal cells, but an HPV test is better at telling us who is at risk for precancer or cancer. You can, as you know, HPV test detects the oncogenic or cancer-causing types of HPV. A PAP or cytology test only shows you abnormal cell changes of the cervix. The beauty of the HPV test, it is objective and reproducible, whereas the cytology test is very subjective. The negative predictive value of an HPV test is extremely important. So what we know about this test is a negative HPV test result has a long-term protection against high-grade histology and cervical cancer. So this shows you 5 years after a negative HPV test or 6 years after a negative HPV test, negative predictive value is extremely strong. So it is extremely unlikely that somebody will have cervical precancer or cancer with a negative HPV test. The lower specificity is something that a lot of people have pointed out. It means it's not as good as our cytology at identifying someone who does not have precancer or cancer. However, when we add in partial genotyping, which we are going to have, so genotyping for 16, 18, and 45, and a reflex cytology test on a positive HPV, we actually improve the specificity. So this is talking about partial genotyping. This will be done automatically by the lab. So any HPV test that is positive will be reported as either 16, 18/45, or other. This is an automatic genotyping that will happen. Now, I've had some questions about cytology. So what will happen to a patient if they have a positive HPV test? And I really, really want you guys to understand that they will not need a second test. The patient will not need to come back to you to have another examination and another swab of their cervix. If they have a positive HPV test, they will automatically run a reflex cytology test on this HPV sample that you have sent in. So it's going to be automatic. It's only one test for the patient. But if they have a positive HPV on the report that you get, it will then tell you what their cytology shows. This becomes very important because that is what will inform you as to what you have to do with them, whether repeat the test or send them to colposcopy. So on March 3rd, this is a hard date, okay? It is coming. The HPV test will be the primary test for cervical screening and will also be used for follow-up of abnormal results in colposcopy. So we're introducing the test in both the screening population and the colposcopy population. This HPV test will only detect oncogenic types of HPV. So again, it's important for us and our patients to understand that if they have a negative HPV test, that means they don't have an oncogenic or high risk type. They may have a low risk type of HPV, which we know can cause minor cell changes and genital warts, but will not cause precancer or cancer of the cervix. Again, reflex cytology and partial genotyping will be automatically performed on these positive HPV tests. So this shows us what is happening in our country, or maybe the 51st state, if some of you have been watching the news. Sorry, I couldn't help myself. So the provinces and territories in blue are planning for implementation. BC has already implemented HPV testing, and PEI has jurisdiction-wide implementation. And the yellow stars are the provinces and territories that are planning for the inclusion of self-collection. So again, this is a hot topic, and a lot of you are wondering about self-collection. So here we go. So we know that self-collection will reduce barriers to cervical screening. There are a lot of people who are uncomfortable with having a pelvic examination. So we're hoping that self-screening will increase participation, decrease barriers, especially in those populations who are under and never screened and are Indigenous populations. This is being implemented in a phased approach in Ontario. So it is coming. At the HPV testing implementation on March 3rd, this is going to be implemented in a small number of primary care sites. I don't have the information as to which sites those are. Eligible participants will be offered a choice between a provider-collected HPV test or a self-collected sample. And as we move forward, this self-collected HPV testing will be phased in. All right, so it is coming, but for the most part, on March 3rd, when we start, this is going to be provider-collected samples. So what are the benefits of HPV testing? We know it's a better screening test for precancer and early cervical cancer. We know it will reduce unnecessary colposcopy referrals, and it will allow us as the colposcopist to discharge patients safer and earlier to prevent them from having more colposcopy than they need. This will improve the quality of screening and colposcopy services in Ontario. Now, I know that there's a lot of excitement around this, but I also know there's a lot of anxiety, especially in those of you who have gone into the hub and looked at all the forms that are there and all the information that is there and all the new pathways that are there. So it's going to take us a little bit of time to get used to new terminology. It's going to take us a little bit of time to get used to new screening intervals, but the bottom line is this is better for our patients and it's better for us. So let's talk about the screening terminology that is going to be a little bit new for all of us. So on the HPV test results, it's either going to say they are HPV negative, which again means they have no high-risk types of HPV. It's going to say they are HPV positive with type 16, 18, or 45, or it's going to say they are HPV positive with other high-risk types. Okay. So, like I said, it's not testing for low-risk types. It's not testing for low-risk HPV, which can cause genital warts. Now, we are going to see some different cytology results coming that we're not used to seeing. So we're used to seeing normal or negative for intraepithelial lesion or malignancy. That is the same. We're used to seeing low-grade results, ASCUS atypical squamous cells of undetermined significance, and LSIL low-grade squamous intraepithelial lesion. But when you look at the list of high-grade cytology results, there are some newer results that you may see. The bottom line is any high-grade cytology result will cue you to do the same thing, which is refer the patient for colposcopy. So whether it says HSIL, whether it says ASC-H or LSIL-H, whether it's atypical glandular cells, neoplastic or otherwise, atypical endocervical cells, neoplastic or otherwise, adenocarcinoma in situ, any of these will be listed as high-grade cytology results and will require referral to colposcopy. So you don't need to get bogged down in what each one of them means. That's more for us in colposcopy to figure out what to do with these patients. You just have to know their high-grade cytology results. What is a cervical precancer? A cervical precancer is an abnormal cell growth in the cervix that is considered moderate or severe, and it includes high-grade squamous intraepithelial lesion or adenocarcinoma in situ. And these are histology results, so these would be biopsy results. All right, so at this point, I'm hoping that I wanted to show you guys this folder, and I hope that you have received this from your lab service provider. But if you haven't received it from the lab service provider, both Life Labs and Dynacare have these available, and they should be giving them to you with your new kits. And in this folder is everything you need for cervical screening. Okay, so I'm just going to show you what's here, because a lot of you are wondering, how do I get all the information? Where does it come from? So in the folder, you have your cytology requisition, and it's important, especially when you're getting the requisition off your EMR, that you're using the cervical screening requisition and not the colposcopy requisition. And I'm going to go through this requisition with you more in a little bit. There is information on how to complete the requisition, so step-by-step instructions. There are copies of the discharge letters that you will get from the colposcopist once the patient is discharged back to your care. And most importantly, well, not most importantly, but there is the whole screening program guide in here, and the pathways and algorithms to follow. So it's all in your folder. And again, if you haven't received this, the region does have some, but you should be getting it from your lab service providers. So this is the meat of the talk, okay? Who is eligible for cervical screening? Number one, they have to have a cervix. Number two, they have to be 25 or older. So now you will not be able to do cervical screening on someone who is less than 25 years of age, with very few exceptions that I'm going to go through later in people who have already started screening. But initiation of screening is now 25 or over, and the labs will reject a sample on someone who's younger than that. They have to have been sexually active. So if you have a patient who's 30, who's never been sexually active, they do not need to have cervical screening. They do not need an HPV test. They need to be covered by OHIP in order to be part of the screening program. And they should have no symptoms of cervical cancer. So if somebody comes in with a growth in their cervix and bleeding, this patient doesn't need screening. This patient needs referral to either a gynecologist or gynecologist to have this investigated further. Okay. So why are we starting at 25? We're starting at 25 because it is extremely rare for anyone under 25 to have cervical precancer or cancer. You're going to start at 25 even if the patients are in the immunocompromised group, and even if they've been vaccinated for HPV. So whether they're immune competent, immune compromised, or vaccinated, they start at 25. Don't screen if they're less than 25, even if they've been sexually active, and don't screen if they've never been sexually active. So again, cervical cancer is extremely rare in this population under 25. Only 29 new cases were diagnosed in Ontario under 25 from 2016 to 2020. And so screening in this age group is actually harmful because it will result in more treatments and tests for these patients that don't need them. There's really no evidence to screen below 25, and there's really no evidence to screen immunocompromised people before age 25. Okay, so the first takeaway is that not everyone who is HPV positive will need to be referred for colposcopy. So it's important to understand that the colposcopy referral threshold is 6% or over. So patients will be referred to colposcopy if they have a 6% chance of having a cervical precancer or cancer based on their screening. And if they don't meet that 6% threshold, they do not need to be seen in colposcopy. We're trying to align with the principles of equal management for equal risk. There are 4 risk-based screening categories. So there's 4 categories that you need to know for screening, okay? This is, their risk category is going to be determined by their most recent cervical screening result and their immune status. So here's the table. So most people are going to fall into the average risk category. These are people who are HPV negative, and you can see that their risk of cervical precancer or cancer is extremely low. And these are the patients who are now going to be screened every 5 years. Average risk every 5 years. We have the immunocompromised group, and I will give you the details on them later on in the talk. We know that these patients are may have more difficulty clearing an HPV infection because of their immunocompromised status, And therefore, the recommendation is to start at age 25, but screen them every 3 years. Pardon me. There's a moderate risk category, which are patients who are HPV positive with the other high-risk types, so not 16, 18, 45, with low-grade or normal cytology. So these patients still have a less than 6% risk of having a cervical precancer or cancer, and these patients do not need to be referred for colposcopy right away and can be rescreened in 2 years. And then we have our elevated risk population, which are HPV positive 16, 18, 45. With either normal or low-grade cytology or high-grade cytology or HPV positive other types with high-grade cytology. I'm so sorry. One moment. I've been doing a lot of talking about HPV the last few weeks. All right, so here is the pathway that we're all going to be following for screening. So we collect a cervical sample, and for the most part, over 90% of patients are going to fall into this category. They're going to be HPV negative, and they're going to return to average risk screening in 5 years for the immune competent population, or average risk screening, elevated risk screening in 3 years for the immunocompromised population. And this just shows you what the rationale is for a 5-year screening interval. So people at average risk are safe to screen every 5 years, and we know that an HPV test every 5 years oh my goodness. So an HPV test, a negative HPV test every 5 years, is as protective as a normal cytology test every 3 years, which is what we've been doing now. So for people who are immune compromised, we know they may be at higher risk because it may impair their ability to clear this HPV infection. So this 3-year interval was selected based on expert panel, scan data, and precautionary principle. So here's the list of your immunocompromised populations. Here are the ones that are, and here are the ones who are not. So, people with diabetes, except if they have renal failure, that's a big part of our population, but they are not considered immune compromised. And what I wanted to show you is you don't need to remember this table. You don't have to memorize it. In the Ontario Screening Guide to Cervical Screening, which is included in the package, which is right here, there is a list of immunocompromised populations who meet the criteria for screening every 3 years, but it's also on the screening requisition, okay? So right at the top, I hope you can see that, there's a list of the immunocompromised population. So it's not something you have to remember or memorize. It's right on the requisition. So back to our pathway, if a patient is HPV positive, they will have an automatic reflex cytology performed on that sample. Once again, they do not need to have another sample taken. They don't need another doctor's appointment. They just will have it automatically done by the lab. So the HPV positive will either be other high-risk types, or it will be positive for 16, 18, 45. This is the category. Remember that they are moderate risk. They're less than 6% chance of having a precancer or cancer. So if they have an HPV positive, other high-risk types, and a normal or low-grade cytology, you will rescreen these patients in 2 years. Sorry. Okay. And the reason for the 2-year interval, again, in 2 years, more than 90% of infections will clear, only 5% will persist, and only 3% will progress. So by giving the 2-year interval, we're giving these patients enough time to clear this infection, and most of them will not require colposcopy. You can see here at the 2-year mark, we're almost at the 90%. So at that 2-year repeat screen, if they're HPV negative, that means they've cleared the infection and they're going to return to average risk screening, 5 years for immune competent, 3 years for immune compromised. If at that repeat 2-year, they're HPV positive, regardless of their cytology, so that means they have a persistent infection, or if at any time they have a high-grade cytology on their first test, doesn't matter what kind of HPV they have, they will be referred to colposcopy. So anybody with high-grade cytology and HPV positive, or someone who has persistent HPV infection at their 2-year screen. And there's the whole pathway for you. And this is, again, that's in that package. It's also on the hub. This is information that you can find everywhere. So this is a good table to sort of have in your office to look at, and it gives you an overview of the screening program. Okay, so what's going to change? The first thing that's going to change, perhaps for most of you, is the test system vendor. So it's all going to be ThinPrep, and you may have to change what labs you're using. So the procured labs for the HPV tests are Life Labs and Dynacare. The North Bay Regional Health Center doesn't really apply to us in our region. Okay, so if you're with Life Labs or Dynacare, you will have them picking up like they do at your office. If you're not with one of those two, you're going to have to reach out to them, or they should have reached out to you to make sure that you have a relationship with them for your HPV samples. So you need to make sure that these tests are sent to one of those labs. No other labs are going to be running those tests. Like I said, if you already have an existing agreement with the labs, nothing is going to change. You will just send your samples the way you normally do. If you don't have an existing agreement, then you will need to reach out to one of those labs to onboard them. So how do you order the test? Number one, confirm that the patient is eligible, over 25, have a cervix, has been sexually active. Next, collect the sample from the cervix, and we're going to go through the details of that. Going to complete the requisition and label the sample, and then submit the requisition and the sample to one of the labs. So collecting the sample, and this is also in that package that the lab will provide. So the sample is collected exactly the same way as a current sample for cytology. Speculum needs to be inserted in the vagina, and the cervix needs to be visualized, the same as you do now. You can use either the broom, or you can use the endocervical brush and the spatula. So you can choose which collection device you want to use. It's important to understand that lubricants should probably be avoided at all times, unless you really have someone who has atrophy. But only use a little bit of lubricant, and make sure it's only on the outside of the speculum blades, not inside the speculum blades, because it can interfere with the specimen, and the specimen might be unsatisfactory if it mixes with the lubricant. You want to make sure your lubricant is carbomer free and it's water soluble. Okay. Now another big change, well, now that we're switching from SurePath, which is the blue vials, to ThinPrep, is that with the blue vials, we used to leave the broom in the vial. You cannot leave any part of the collection device in the vial anymore. If there's a collection device in the vial, the specimen will be rejected by the lab. So that's an important change, because most of us were pushing the broom into the vial before. Make sure all samples are labeled with the name, date of birth, date of sample collection. So again, we are not using SurePath anymore. We are using ThinPrep. So if you have the blue vials, you should get rid of them on March the 2nd. Okay, you cannot use them anymore. They're not going to be useful. You can only use ThinPrep. And again, please do not leave any part of the collection device into the vial. How to avoid your cervical sample being rejected. Make sure that the vial is not expired. Again, no part of the collection device can be in the vial. Make sure it's labeled legibly with a printed label, and all parts of the requisition also need to be filled out. make sure it's not leaking. And this is kind of common sense, but sometimes it happens. And then make sure it's sent promptly to the lab. Okay. In terms of some special populations, if you're collecting a sample from someone who's pregnant, there's no reason you cannot do cervical screening on someone who's pregnant, but you should not use a device that enters the cervical canal. So it's best to use the spatula with no endo brush for these patients. And typically, cervical screening is avoided in pregnant patients after 24 weeks because it can be more comfortable, but it can be resumed as early as 6 weeks postpartum. If you have a patient with a double cervix, so this is rare, but it does happen, you're going to collect one sample from each cervix, and you're going to use a separate collection device, so a separate broom and a separate vial. And each vial needs to be labeled either right or left cervix, but you only will fill out a single requisition for these patients. And there is a box on the requisition that you can tick off that says double cervix. If you're collecting a sample from the vaginal vault, either the broom or the spatula is appropriate. You're going to go to the top of the vaginal vault and just go back and forth with the broom about 5 times. So there were some questions about how to fill out the requisition. So number one, it's important to use the correct requisition. The correct requisition is the Ontario Health requisition for cervical screening. No longer are we using these old requisitions or the lab specific requisitions. Okay. And what are the main changes? So it's a brand new requisition. And the first thing is there's eligibility information at the top. So it tells you who's eligible. It lists those immunocompromised populations. And there's even links if you need to go and find more information. There is also testing indications on the requisition. So it asks you, why are you sending this in? Is this average risk screening every 5 years? Is this immunocompromised screening every 3? Is it a repeat 2 years later for an HPV positive with low-grade cytology? Is it a post-colposcopy 2-year follow-up? Or is it a post-hysterectomy follow-up? So all of your categories for cervical screening are listed right there. And you're going to need to tell the lab which one you're going to need to tick off one of these boxes. If it's not ticked off, the specimen will be rejected. There is a box for cytology test only, and this is only to be used if the patient has had a previous HPV positive with an unsatisfactory cytology result. So you will not be able to just order cytology, and the lab will know if the patient has not had a previous HPV positive and unsatisfactory cytology. So if this box is used inappropriately, the specimen will be rejected. So how to complete the requisition? This was a question I got before the webinar. First, you need to enter your information, and you may want to copy the primary care. If there's another provider, you may want to send them a copy. You're going to enter the patient information or put the patient label on the specimen. You're going to fill out the screening testing indications. Only one box can be checked. And then you're going to enter the information that applies to the specimen. So these categories are on the current requisition that we have. Does the patient have an IUD? Are they on hormone therapy? Are they postmenopausal? Are they postpartum? Are they pregnant? Have they had a subtotal hysterectomy? And then there's a category also for transition-related hormone therapy. So some patients who may be on androgen therapy. It's important to let the lab know. There's a specimen collection date field. There's a last menstrual period field. There's clinical information if you need to add something else in. And then you need to sign and date the requisition. So where can you find the requisition? The requisitions can be found in that package that I showed you, but they're also on the Ontario Health HPV Hub. This is a very useful website, and I hope that all of you have this bookmarked already. If you don't, take a screenshot or write it down. Every piece of information that I'm telling you today and that you need for cervical screening and the changes that are coming with HPV implementation is on this hub. It's very, very, very useful, okay? Now, of course, big question, will the EMRs have this requisition? Yes, they will, okay? So Ontario Health has been working with Ontario MD to have these requisitions available in the EMRs. So far, 8 EMRs have confirmed that they're going to have the requisition forms ready to go before March 3rd. You may not find them there yet because you cannot use this requisition as of now. It's only going to be accepted on March 3rd and thereafter. So the EMRs are a little bit hesitant to put it on there beforehand because they don't want people to use them. Okay, so here's the list of the EMRs that are confirmed. This is up to date as of last week. Hopefully this encompasses most of your EMRs. You can always reach out to your EMR to ask if they have a date confirmed, and if you don't see them on this list, please know that Ontario MD is still working with them to make sure they're going to have it available. It's unclear whether the EMRs are going to be putting the colposcopy requisition on the EMRs as well. If they do, it's very important that you remember you need to use the one for cervical screening and not for colposcopy. They look very similar, but we haven't heard back from the EMRs about if they're putting the colposcopy one there, so there may only be the one, which will make it simpler in some cases. So why could this be rejected? It can be rejected if the patient's not eligible. So if they're not 25, they're not due for screening, if they've been screened within the last 5 years and you're trying to order another HPV test, that will be rejected. If it's incomplete or illegible, if it's received without a cervical sample, if there's duplicate requisitions, if it's an inappropriate cytology only request. So please don't use this box unless it's appropriate, because they're going to be rejected, and then the patient will need to have another pelvic exam. If you choose more than one testing indication, or if there's a missing testing indication. So it's important to complete the requisition accurately to avoid rejection of the sample. So how are we going to manage invalid HPV tests or unsatisfactory cytology results? Okay, so when do you repeat or when do you refer? So if you have an unsatisfactory cytology or an HPV test which is invalid, you can repeat the specimen as soon as possible. So repeat the specimen within 3 months. You don't need to repeat the specimen if the HPV test is positive for 16, 18, or 45 with unsatisfactory cytology. So these patients will be referred right to colposcopy. And if you have 2 consecutive unsatisfactory cytology or invalid HPV test results, those patients will also go to colposcopy. So it's important to remember that you don't have to keep repeating. If you have 2 in a row, unsatisfactory or invalid HPV tests, they'll be referred to colposcopy. Or if you have a positive 16, 18, 45, doesn't matter what their cytology shows, they're going to go to colposcopy anyway. You can consider intravaginal estrogen therapy after 1 unsatisfactory cytology in people who are using androgen therapy or in postmenopausal people. So remember, if there's considerable vaginal atrophy, then estrogen therapy may help make that cytology more satisfactory. Okay, when do you stop? How are we doing for time? Okay, so you can stop screening typically in people ages 65 to 69. So if the patient has not been screened between ages 65 to 69, then they should be screened until they're 74. So you have a group of people who have not had a cytology test. They need to have that'll be at least 2 negative HPVs to reduce their risk, so they can go on till 74. If they are HPV negative between 65 and 69, you can stop screening, except for immunocompromised population, which should continue until 74, or people who are in this age group, 65 to 69, who have come back from colposcopy and need to have continued screening until 74. And this will be communicated to you by the colposcopist on their discharge sheet. If they've had an HPV positive between 65 and 69, you're going to follow that screening pathway and refer to colposcopy if you need to, and you can stop screening when they've had a negative HPV or when they get to 74, whichever occurs first. It is not recommended to screen people over 74. So people 75 or over do not qualify for the Ontario Cervical Screening Program. If you have someone in the 70 to 74 range with an HPV positive result, they should be referred directly to colposcopy to exclude a high-grade lesion. So in this population, an HPV positive, regardless of HPV type, regardless of cytology, they should be referred to colposcopy. Again, don't screen people over 75. If they have a visible cervical abnormality, they need to be referred appropriately. So, in summary, key changes. We're moving from cytology to HPV test with reflex cytology. We will have partial genotyping and reflex cytology on all HPV positive specimens. Average risk population is screened every 5 years. Immunocompromised population is screened every 3 years. If they need, if they had a low-grade cytology before, you're repeating their cytology in 1 year. Now, if they have a HPV other with low-grade cytology, you're repeating it in 2 years. You're starting at age 25, and you're going to stop between 65 to 69 if they've had a negative HPV test. So after HPV implementation, after March 3rd, you will not be able to order a standalone cytology as primary screening. So there will be no more ordering of the PAP test, and you will not be able to screen people under the age of 25. Now, this is the caveat of the under 25. If somebody has started screening already between 21 and 24, this is a good question that a lot of people are asking. What do we do with these people? So if they have started screening already, before HPV test was implemented, you're going to start HPV testing when someone is due for their next cytology test. So if they had a cytology at 21 and they're due in 3 years at 24, at that point, they can have the HPV test, okay? And this information, again, is available on the hub. So if they had a normal cytology, let's say at age 21, you can actually delay their next screening to 25, or you can do it in 3 years, whichever comes later. So for that patient, you might just wait until they're 25. If they're immune compromised, you're going to delay their next screening until 25 or 12 months, whichever comes later. So the immune compromised population is a little bit different. If they had an unsatisfactory cytology, you can delay their screening until 25, or you can repeat the test at the patient's earliest convenience if they want it. In the immune compromised population, same idea, you can delay till 25, or if requested by the patient, you can repeat it. If a patient has had one low-grade cytology, you can delay their screening until 25. Some of these patients in the current screening program would have been repeating their cytology at a year. If you have already discussed that with them and they want their repeat cytology, or they want their repeat test of the year, then they can have a repeat screen, which will now be an HPV test. If they're immune compromised, they should repeat the screen in a year. And like always, if they've had 2 low-grade cytologies, they need to be referred to colposcopy, or if they've had 1 high-grade cytology, they need to be referred to colposcopy. So these colposcopy referral criteria do not change because they're 21 to 24. In pregnancy, people should still be screened. So pregnancy doesn't affect someone's risk of developing cervical precancer or cancer. You can screen them when they're due or if they're overdue. Usually we don't screen in the 3rd trimester, and that can be deferred to the postpartum period. The screening recommendations and the indications for referral to colposcopy are the same for all average risk people, regardless of pregnancy status. Again, if you're collecting a cervical sample, don't use anything in the endocervical canal. So just use the spatula, and typically try to avoid screening after 24 weeks for patient comfort. The double cervix. So how do you collect? The same way as you would collect normally. Visualize the cervix, but you're going to use 1 collection sample from the right cervix, 1 from the left. You're going to use 2 different vials and 2 different brooms, but you're only going to submit 1 requisition. Now, with people with a double cervix, they're actually going to get 2 result letters from the screening program. and their management should be based on their most severe result. So if they have a normal or an HPV negative in one cervix, but an HPV positive in the other cervix, their management is informed by their most severe results, the HPV positive, and you would refer them or repeat their testing based on that. So I did want to talk a little bit about what's going to happen in colposcopy. All of our colposcopy guidelines have changed as well. We have 7 different pathways. And the most important change in colposcopy is people will have an episode of care in colposcopy. So they will be referred into colposcopy with their HPV and cytology. We will deal with that depending on what their results are. They might require 1 colposcopy, they might require up to 4 colposcopy visits, but each one of those pathways is an episode of care. And when they're discharged from colposcopy, they will go back to you with very clear recommendations and guidelines as to what comes next. Now, these tables are in your package. And what I really wanted to simplify for you, because when you start looking at all these pathways, it's easy to become cross-eyed and they all start melding into each other, and it's really, really difficult to keep them straight. But what's going to happen in colposcopy is they are either going to be referred with low-grade cytology or high-grade cytology. They're all going to be HPV positive, right? So in colposcopy, it's actually the cytology that informs us as to what pathway we need to follow. In patients who do not have proven high-grade histology, so in patients who are referred into colposcopy, they have either 1 colposcopy or 2 colposcopies where we cannot find any high-grade lesions. They're going to be discharged back to you, and they only need 1 negative HPV test to go back to average risk screening. So if we've never found high-grade change, whether we've seen them once or twice, they will only need 1 HPV test to return to average risk screening. If we find high-grade histology, whether that's HSIL or adenocarcinoma in situ, we're going to treat these patients. We're going to see them post-treatment for 2 visits. And these patients will need 2 negative HPV tests to return to average risk screening. So when you get those discharge letters, which they look really complicated when you look at them because there's lots of tick boxes and there's lots of different if this, then this, and if that, then this. If simplify it in your mind. If they've never had high-grade histology, they only need 1 negative HPV test to return to average risk screening. And if they've had high-grade histology, they need 2 negative HPV tests. And some of those HPV tests may be done by us in colposcopy. But one of the most common situations that we're going to encounter is we're going to encounter that patient with the HPV positive low-grade cytology. So these patients are going to come into colposcopy, and for us, we only need to see them once, and we may discharge them right back to you. And they're going to need an HPV test in 2 years. And if that HPV test is negative, they go back to average risk screening. And again, this is all in the letters that need to be sent to you, and it's the colposcopist's responsibility to make sure you have the information that you need. Okay, and the discharge letters are pretty clear once you go through them. All right. Like I said, you're going to resume screening either 5 years after colposcopy if they've had the negative HPV test, or they're going to be 2 years if they haven't had that negative HPV test. People at elevated risk will remain in colposcopy until we've sorted them out. Okay, so what this table shows you again is for people who are not treated. Those are the low grade cytology and histology. We've never found high grade. So they're going to, if they have 1 HPV negative, they're going to, that's this one here, return to average risk screening. And if in this post-colposcopy discharge time they ever have another HPV positive, they go back to colposcopy. So I'm not going to spend too much time on these tables because, again, I don't want you guys to go cross-eyed, okay? This one a little bit more complicated. In patients treated for adenocarcinoma in situ, they need ongoing screening, and we're going to keep them in colposcopy for almost 5 years before we discharge them back to you. This just is an overview of the post-discharge screening again, and this information can all be found in your packages. Okay, what are the takeaways? Some people are going to be discharged after only one colposcopy visit. Some people may still be HPV positive when they are discharged back to you. And if they're discharged back and they have another HPV positive test at their 2-year screen, they're going to come back to us in colposcopy. Again, these are samples of the discharge letters that you will be getting. If you don't get a discharge letter from a colposcopist, you should contact them and ask them for clarification. It is our responsibility as the colposcopist to make sure you have the information you need in order to continue this screening appropriately for this patient. It's not your responsibility to figure it out. And it's also my responsibility to make sure the colposcopists in our region know this, and trust me, I'm on it. Okay, let's talk a little bit about vaginal vault testing. I know we're getting close to 7 and I've bombarded you with information. So if people who have had their cervix removed are not at risk of developing cervical cancer, they're not at risk of developing cervical cancer, but they may be at risk for developing vaginal cancer. It's really important to understand that vaginal cancer is extremely rare. It's an almost never. We see it almost never. So vaginal vault testing is not something we need to do very often. In the post-hysterectomy population, we have come up with a guideline to try to guide vaginal vault testing post-hysterectomy. So there's an elevated risk group and there's a low risk group. So the low risk group is people who have a history of changes of their cervix, cervical dysplasia, but they did not have any evidence of this in the hysterectomy specimen. So they may have had a hysterectomy after being diagnosed with LSIL, but there is no dysplasia in the hysterectomy specimen. This is a low risk group and they don't need vaginal vault testing. In patients who have not had cervical screening or unknown cervical screening, but they do not need to have vaginal vault screening, vaginal vault testing just because they haven't had screening. Okay, so your higher risk or elevated group is people with cervical dysplasia in their hysterectomy specimen, regardless of margin status. So if they've had LSIL, HSIL, or AIS in the hysterectomy specimen, they are eligible to have a vaginal vault test, or people who have a stage 1A1 microinvasive cervical cancer. Anybody with more advanced stage than that is going to be followed in the cancer center. Okay, so if they've been treated for cervical cancer beyond stage 1A1, they will not need a vaginal vault specimen. So in the elevated risk group, they can have one vaginal vault test about 6 to 12 months after the hysterectomy. If that's negative, then they don't need any more screening. If they have an HPV positive, they're going to have a reflex cytology and be sent to colposcopy. In the low risk group, they don't need an HPV test. And it's important also that the colposcopist lets you know if they've done a hysterectomy on a patient with cervical dysplasia, if a vaginal vault test is needed. Okay. How are you going to manage these? Any HPV positive vaginal vault test gets referred to colposcopy. If they're negative, they don't need any further screening. And if the HPV test is invalid, it should be repeated. So if somebody has an unknown HPV status before HPV launch, so this is also for vaginal vault testing. So if their most recent cytology or vaginal vault test was normal, they don't need anything further. If their most recent cytology of the vaginal vault was unsatisfactory, and if they meet the criteria for vaginal vault testing, so that elevated risk group, that they can have an HPV test. If they don't meet the criteria for vaginal vault testing, then they don't need any further vaginal vault testing. If they had a low-grade cytology of the vaginal vault, repeat that in a year like you normally would. If they had a high grade, they go to colposcopy. And obviously, if they have a high grade that shows carcinoma, they should be referred or seek any oncology. Health Canada the vaginal vault test is actually not approved by Health Canada, and so there's a disclosure statement that is included with vaginal vault testing that the HPV test is actually not designed for vaginal vault testing. Okay, so you will get a report that tells you the patient's HPV status, and if it's positive, the cytology results. So this will come on one report from the lab service providers after you've done an HPV test. It'll say their HPV status, either positive or negative or positive, and if positive, the cytology results will automatically be included with the report. You'll also be notified if the results are invalid, if the cytology is unsatisfactory, or if the sample was rejected. Okay. These reports will be accessible on OLIS, so you will be able to search for their last HPV test. And patients will also be supported, like they are now, from the Ontario Cervical Screening Program with invitation and recall letters, reminders, and results. Sometimes you can have a physician-linked correspondence for the patient. Your resources. So again, this HPV hub is really, really useful. Please access it. Go on, look what's there. Everything is there. The instructions for completing the requisition and the requisitions, how to collect the sample, everything I've gone through. There's some frequently asked questions. There's the decline referral letter from colposcopy. So hopefully this isn't something that you guys see very much, but if you refer someone to colposcopy, you may get this back that says they're not eligible for colposcopy based on their referral criteria. And if the colposcopist is really nice, they may tell you what your next steps are. There's the guide to cervical screening, and then there's the guide to resuming post-colposcopy. Okay, so there's a few quick case studies we can go through, and then I'm going to stop sharing and I'm going to try to answer any questions that we have. These won't take long, so we can go through them. So case one, Alex is 28 and due for cervical screening. She has her screening and it's HPV positive other with a low grade or ascus reflex cytology. What is the next step? So I'll give you guys a minute to look at these. So is Alex at moderate risk and needs a repeat HPV test in 2 years? Is Alex at moderate risk and needs a repeat HPV test in 1 year? Is she at elevated risk and is referred to colposcopy, or is she at average risk and returning in 5 years? So you can put your answer in the chat, but I'm going to just tell you that answer A is correct. So she's moderate risk. She's HPV positive other with a low grade cytology. So we're going to give her a little bit of time to try to clear this infection and repeat her HPV test in 2 years. When you repeat the HPV test in 2 years, she gets a letter from Ontario Health reminding her to get tested again. And she goes and has another HPV test, which is positive for other high-risk types with a low-grade reflex cytology. So what is her next step? Is she still at moderate risk and repeat HPV test again in 2 years? Is she at elevated risk and needs referral to colposcopy, or is she average risk and needs screening in 5 years? So you guys all know that with the persistence of the infection, she's now at elevated risk and she needs to go to colposcopy. So 2 positive HPV tests 2 years apart, refer to colposcopy. So she's seen in colposcopy and she's assessed, and we cannot find any high-grade histology. So she doesn't need treatment. So she's going to be referred back to you with a letter that says Alex is still at moderate risk because she was referred with a positive HPV test. So even though we didn't find any high-grade histology, she needs to be screened in 2 years. So 2 years later, she comes back to you and she has an HPV test which is positive with normal cytology. What is the recommended next step? Does she go back to colposcopy? Do you repeat again in 2 years? Do you rescreen in 3? Do you rescreen in 5? So this is a good example of the patient who is still in the moderate risk category, has not had their negative HPV test. So they are still positive And so they need to be referred back to colposcopy because they have not reached their threshold where they're negative and can enter routine screening. Case study number 2. So Sarah is 68 and received routine cervical screening with an HPV test. So she's due for screening, and she has an HPV positive other with a normal reflex cytology. So what is her next step? So she's 68. Do we stop screening? Do we refer to colposcopy? Do we repeat the HPV test in 2 years and then refer to colposcopy if HPV positive, regardless of HPV type or cytology? And do we repeat HPV test in 2 years and stop screening if it's negative? I'll give you guys a second to think about that one. So both C and D are correct. You're going to retest in 2 years. And if she's positive, she needs to go to colposcopy. If she's negative, we can stop screening. So this patient is a 70-year-old, has not received cervical screening in a long time. So she makes an appointment. She has an HPV test, which is positive, with a ascus reflex cytology. What are you going to do with this patient? So in the 70 to 74 year range, and someone who has not been screened, any HPV positive goes to colposcopy. So you wouldn't retest in 2 years because she hasn't had screening for a long time. She's going to be sent right away. Okay. And the last one, Ricky is 22, is a transmasculine person who just got screened, just before primary HPV testing was implemented. Okay. So he had a cytology, which was low grade, and he's 22. So now we're in HPV testing mode. How and when should he be screened next? So are we going to delay rescreening with HPV test to 25? Are we going to rescreen in a year with cytology alone? Are we going to rescreen with HPV test at 23 or A and Z? So sort of a giveaway. So with this patient, he started screening before age 25, so we can either delay until 25 because he just had a low-grade cytology, or after discussion, he can rescreen in 1 year with an HPV test. Okay. Case 4, Mary is 49 with a history of cervical dysplasia. She had a hysterectomy 6 months ago, and there was evidence of high-grade change or HSIL histology in the hysterectomy specimen. So she has an HPV test of the vaginal vault, and the result is HPV negative. What is the appropriate next step? Refer to colposcopy, cease testing, or repeat in 2 years. So this is the one-time vaginal vault, HPV negative. She can cease testing. And I think that is the end of the slides. So I am going to stop sharing, and I'm happy to take questions if somebody wants to. Are people able to turn on their microphone and ask questions?
Yeah, I think so. I think Mark Phillips, I think, has his hand up. So if you want to
Okay,
unmute and
good.
ask your question, Mark.
I'll just allow the mic.
And
You're muted, Mark, so I can't hear you.
there are 3 people with hands up.
Yeah.
Perhaps while you're waiting, you could just put your questions in the chat as well, and in case we can't make this work with audio, or in the Q&A, excuse me. Thanks.
So I can go through some of the questions that are in here if we, Tracy Cohn asked, so for people who have had a reflex HPV test they paid for, do we have them wait 5 years to give them another one? So if they've had a negative HPV test and, well, let me go back. So with HPV implementation, we shouldn't be bringing people in earlier to screen. Okay, so we should still do the screening at the recommended time. So if somebody's due for a screening test in 2 years, they should come in 2 years. If they're due in 3 years, they should come in 3 years. So for this patient, if they had a negative HPV test, technically you could bring them back in 5 years. According to current guidelines, they would need to be screened in 3 years. But we know that the interval of 5 years is safe, knowing that they had an HPV test. So that would be acceptable. The next question, is there a patient handout we can access to send to our patients to help educate them on the change and avoid lengthy conversations to explain the change? Good question. I don't know if they've actually come out with a specific patient handout, but I can certainly find out. Alan, do you know?
I don't know.
I haven't seen that. So I can ask at the provincial level and see if they've come out with anything.
Dr. Lackman, actually, there is a patient-facing resource that is available on the hub.
Okay, great.
Okay,
On the
excellent.
HPV hub.
Yes, I believe it's at the bottom of the page.
Okay, all right, so you can look there. The next question is about testing for GC and chlamydia. So that is not on this this current requisition. So the requisition for cervical screening only has cervical screening on it. If you want to test for GC and chlamydia, you can do the separate swabs and send them with the regular routine requisition.
I had my hand up. I have two questions, if you don't mind.
Sure.
Lots of background baby noises. The first one is an easy one. One of the clinics I work in, I think, was very keen and put in the new requisitions early. So I did a couple of PAPs with this new requisition. Are they going to get declined now?
Probably.
Okay, I'll have to contact Life Labs and send a new one. And my second one is a question that I've come across already in discussing this with patients. The first one being, that question being, a lot of patients will say, oh, I'm very anxious about it, moving from 3 to 5 years. Is this a money thing? And can I just pay to have one at 3 years instead? How would you approach that?
So it's important to explain to the patient the safety of the HPV interval at 5 years and that it's as protective as a PAP or cytology at 3 years. Because of the natural history of the HPV infection, and it takes 15 to 20 years for precancer cancer to develop, a 5-year interval is extremely safe. Now, patients are either going to believe us or not. And, we all have the patients who think that screening more often is safer. The best we can do is explain to them the natural history of this infection and the fact that only 3% of infections will persist. And we can pick it up early because it takes so long to develop into high-grade precancer or cancer.
Excellent.
But they
Thank
won't
you
be
so
able
much.
to pay for it through the program.
Great. Thank you.
And that's the paradigm change that I'd suggested at the beginning of this, is that we're actually not looking at the effects of the infection. We're actually looking for the infection. So we're going sort of right to the horse's mouth, so to speak. So if they don't have an infection, they're not going to get changes in their cervix leading to cancer. So that discussion can actually make a big difference in hopefully helping that solution. The next question was, if the sample comes back inadequate, how soon can we repeat the test?
So as soon as possible, within 3 months is preferable.
Okay,
We talked about the indications for vaginal vault screening, so that's there. It's on the hub. Is there any reason for not using a brush in early pregnant women? Not really. The endo brush or the broom? I'm not sure which one you're referring to. So the endo brush should not be used in early pregnancy. It shouldn't be used anytime in pregnancy. Nothing should really go into the canal. The broom doesn't really go up far into the canal, but I would recommend you just use the spatula for any cervical screening test in pregnancy.
You're going to worry a lot of people with bleeding if you use something invasive. That's the reason why you want to avoid it.
Does the label on the collection bottle require the date of collection? I don't think so. That just needs to be on the requisition.
Best to put a sticker on the bottle altogether if you can help it.
Does eligibility depend on when their last pap smear was, or do we roll out everyone eligible all at once? So again, you shouldn't be bringing people back in earlier than they need to be screened. So if somebody had a normal cytology, let's say last year, a normal pap, they should come back for their 3-year like they would normally. And at that point, you're going to introduce them into HPV screening. But you shouldn't bring them back earlier than when they need to be screened. Okay, so if somebody needs to be in 2 years, do it in 2. If somebody needs 3, do it in 3. Like if somebody had a pap in January last month, they don't need another test for 3 years.
Michelle asked AI about what's immunosuppressive, and you got quite a detailed answer, Michelle. But remember that you have to fulfill the criteria on the requisition, otherwise they're going to throw it back at you. So these answers are certainly not unreasonable, and I think it hits most of the things we already talked about, but it does leave out things like lupus and dialysis and stuff like that. So it's not a comprehensive answer. So we're not quite ready for AI to answer all our questions just yet, but you have all the answers on the requisition for what's considered immunocompromising.
The next question is, if someone has IFH coverage, is that person eligible for cervical cancer screening? That's a great question. I don't actually know the answer to that one, but we can certainly find it. Next one is 25-year-old patient with.
Rakaya might know.
I had my hand up, and it's apropos what you just answered there, because
Okay.
I work at a community health center, and we have a lot of IFH patients, and we also have non-insured. So what is going to happen to those people? I understand you don't know the answer, but do we use the old screening for them? And when it came to FIT tests, Dynacare, again, Life Labs is doing the insured FIT test, but Dynacare is doing the non-insured. So we send our non-insured FIT kits to them. So is that something like that going to happen? Because otherwise we're leaving out a very large population.
That's a great question. I think that would be a good, I'm going to write to the provincial team and ask them about those particular situations. And then I can have Rukia send back an answer when I get it. Okay.
Thank you.
You're welcome. Does someone else have their hand up that wants to ask a question? Okay, I'll keep going.
Yes, I have my hand out.
Oh, go ahead.
I'm Maya. Thank you very much for the talk. So one question, I'm a bit confused here. What about, we know the reasons for cervical cancer can be obesity, genetics, smoking, family history. So we're focusing more on HPV. What about people that they have family history of cervical cancer, or the obese people or the smoker? What should we do for those?
So HPV infection is a necessary condition for developing almost all cervical cancers. So heredity doesn't really play into cervical cancer, except if it plays into their immune system and the way they deal with an HPV infection. But without a positive HPV infection, people can't develop cervical cancer unless it's an unusual, like a cervical, lymphoma of the cervix, or sarcoma of the cervix, things that we almost never see. So with an HPV negative, those other risk factors don't really play in too much.
Thank you.
You're welcome.
Next question from Jordan asking about a patient 25 years old with ascus on a PAP. She had HPV then done after, which was positive for 16-18. And the question is when to repeat. PAP says a year. Our guidelines say rescreen in 2 years.
Right.
What do we do?
So right now, our guidelines would say to repeat in a year. But according to new guidelines, it would be very safe to repeat this patient screening in 2 years and do their HPV test at that point. Chances are that patient is going to clear her infection. And if she doesn't and has persistent infection, then she'll be referred for colposcopy.
So it's early on in the course. She's only 25, so yes, lots of time.
Yeah, and it wouldn't be wrong to repeat it in a year, because that's our current guideline. So technically we can't implement these guidelines for another month. So if you did screen in a year, that wouldn't be incorrect, but this patient is safe to screen in 2 years. The next question, does recurrence of moderate risk result 2 or more years later change the risk category to higher risk and thus rescreening or colposcopy advice? So what I'm interpreting there is, if a patient is HPV positive with a non-16-18-45 type and needs a repeat in 2 years, if they're still positive at that point, then this patient would be now at elevated risk and would need to go to colposcopy.
So what if they're positive, then they're negative, then they're positive again?
So if they're negative, they would go back to 5-year screening, right? Because they've never had a high grade. And then if they're positive again, they start again. So if they're positive again, then they need a repeat in 2 years.
Yeah, so you don't go back to 2. It's not 2 suddenly, it could be high risk. So that's important. So you're starting over again once you come negative.
correct. Who makes the referral for colposcopy? The primary care provider, whoever did the cervical screening could do that.
Yeah. Yeah, it's not done automatically by the program. That's what's important there. So you still have to do that. And we do have a list of colposcopists on the site as well for you to check in your area.
If a patient has LSIL on PAP currently, should the HPV test be done in 12 months? So yes, this is a patient who would be recalled for their screening 1 year later, and then you're going to do an HPV test and follow the guidelines going from there. Who makes the decision on colposcopy? I'm not sure
Yeah,
what.
I think we answered that already. You're going to get the information in a letter back to you, and then you have to make the referral.
IFH, we're gonna find out about that. Define sexual activity. So sexual activity is genital touching. Okay, so it has to be involving the genitals, but does not have to include penetration. So it could be hand to genital, could be oral to genital, but any genital touching, any genital contact is considered sexual activity.
Of any sexual persuasion, to answer Jack's question a few more down. So
right. Jack. Anyone who touches anyone else's genitals or has their genitals touched. Right. For previous colonoscopy discharge from gynae patients, how often should we do HPV PAP? So I'm assuming that meant colposcopy. So the guidelines for screening, you should follow according to what the patient currently needs. So it depends on what they had done in colposcopy and the recommendations when they were discharged. So there's going to be different guidelines for those patients. Will there be an organized colposcopy program with monitored wait times so the patient receive a copy of the result? So the colposcopy program is organized. There is a quality
assurance
assessments that are done. So there are patient discharge letters from colposcopy that we will be sending them when they're discharged, so they will also know what their next steps are.
Cancer Care Ontario monitors everything, guys, including wait times for abnormal tests. So we'll be looking at this over time, and I'm sure initially there's going to be quite a load of colposcopists, both for discharging people who can be discharged and all the new HPV positives. So I think we're going to have a little bit of a growing pains to start with this, but then things should slow down and improve quickly.
Yeah, what you're going to see is likely a slew of patients being discharged from colposcopy. There are a lot of patients in colposcopy right now who don't need to be there. And so with this testing, there's going to be a lot of patients moving out of colposcopy, which is important because we need to make room for those new patients who are going to be referred. In any jurisdiction that has implemented HPV testing, the colposcopy referrals have increased by about 10% at the beginning. Will we still be using a broom and liquid, or will we have to order new kits? So the kits should come from the lab. They've already started bringing these to cervical screening providers. So you should have your new kits. It is a broom or a spatula and an endobrush and the thin prep vials. Is it safe to assume that self-testers who test oncogenic HPV positive will then need to come in for a physical examination? So this is why self-screening is being phased in, because we need to figure out the process of getting these patients to the right place, whether they need another test in 2 years, whether they need colposcopy. So it's slowly being phased in. And as we phase this in, we're going to have guidelines as to what these patients need to do and what the next steps are.
But Felice, the positive HPV with self-testers, will they be able to do the reflex cytology on those samples?
Good question. I don't know the answer.
That would be my concern. So I think, Robin, you're probably right. It's going to be an issue where they are going to have to come in and get an examination and get a cytology as well, because it's unlikely they're going to get a proper sample for cytology when they self-test. So we'll have to see how that goes.
And yes, Dina, the meeting is recorded.
Still some people with some hands up. Anybody want to unmute and ask any questions? And sorry, I didn't mean to cut you off, Felice. Yes, we are.
There's questions in the chat too. There's tons.
Oh, okay. So many places to monitor. Sorry.
Yeah. Okay. If a patient has a positive HPV, I'm starting from the bottom here, so the most recent ones. If a patient has a positive HPV test and associated associated high risk cytology, gets treated and has negative HPV test, then a recurrent HPV positive. Is this the same infection persisting or new HPV exposure? Does new versus persisting change what pathway is taken? So it's a good question. If they've tested negative and then they test positive subsequently, it's very possible this patient has been exposed to new HPV. Patients do have different partners, or partners have different partners. So it's very hard to know. But persistent infection or new infection will be treated the same way. If they've had that negative HPV test, and presumably, according to your question, they've been treated for high-grade cytology, which means they had 2 negative HPV tests before going back into routine screening, then we can assume it's probably a new infection. If they've only had 1 negative HPV test and then their second 2 years later is positive, that could be recurrent, a persistent infection as opposed to recurrent infection.
A question about why can't CCO make automatic referrals for abnormalities rather than making this go through the family doc? It's a really good question. We've been talking about it amongst all the regional primary care leads for all the different cancers, trying to do this and make it happen automatically. Right now, the system just isn't set up for it, but it is something we're trying to work towards because it'll certainly make the system more efficient. It would require a much more significant workload for Cancer Care Ontario. So right now, it's still in our bailiwick as primary care guys, but it is being looked at right now in all the different cancer screening programs.
Okay, so you answered that one. If someone is HPV positive, would you recommend HPV vaccination? Would HPV vaccine covered by OHIP in any of these cases? So I need to start by saying vaccination is not a purview of the Ontario Cervical Screening Program. It is a public health initiative. There is some evidence that vaccination increases immunity and that some people will better clear the virus even if they get vaccinated after exposure. But it's very it's a personal decision the patients have to make because, as you know, the vaccine is not covered and it's quite expensive. So it's difficult to recommend it without a lot of good evidence to say it's going to help them. And we don't really know. It's not harmful in and of itself, but the cost may be harmful to some patients.
How long can the sample sit before going to the lab?
I don't know. Send it as soon as possible.
Yeah.
The lab can answer that question.
Can I ask a question? Finally, my mic is open.
Sure.
I'm Roya. And Dr. Lackman, I'm not sure if you know about, I'm sure you don't know because I don't think you know about the family doctor's work on this, but you describing it very nicely. I don't know about Alan. I have a big question for OMA that I'm going to put that question later on, but I just need to know, according to you guys as experts, do you think with this new program, our job is easier or harder as family doctors?
I can go first if you want, because I've thought about this question, and I think it makes our job much easier. Again, we are looking at the problem, not the effect of the problem. We're looking at the infection, and we're looking at which people have high-risk infection, and everyone who does not have high-risk infection really doesn't have oncogenic strains, just does not have a risk of cervical cancer, no matter what the cytology is showing. So the cytology, all the list of different cytology acronyms and so on, I still don't have them all straight after years in this job, despite the fact that Dr. Lackman's tried to teach it to me a number of times. So it's just hard. So HPV, it's sort of it's a either positive or negative, and that takes you down one different pathway. And then from there, all the rest of these decisions are going to be laid out very nicely in the result letters. So while it looks initially complicated, I think after all, it's going to make people a little more straightforward and make it easier to explain. But what do you think, Felice?
I think at the beginning it's intimidating because new pathways, new guidelines, and lots of new things to get used to, different recall times for different populations. And so in that perspective, I think it does make it a little bit more difficult. But the bottom line is it's a better test and it's going to send appropriate people for colposcopy, and it's going to obviate the need for needless testing on some people who are getting a lot of cervical tests right now. So there's going to be a little bit of pain at the beginning, because it's something new to get used to. And I know when I give these talks and I show the pathways, eventually it all becomes blurry and it's very difficult to keep straight. But after doing it for a while, it's going to become second nature. Just like when FIT was introduced, just like when our PAPs went to every 3 years, we'll learn and we'll get used to it.
And we do have those sort of pathways there that are in the tool section of the website. So you can look at that, and when you get stuck, just go down the pathway and just run yourself through it. You're going to find the answer. So it will be hopefully very self-evident for how to do that. So you want to go from the top, and I'll start going from the bottom, please, if you want. There's still some more questions.
Okay. Oh my goodness, there's a lot of questions here.
Yeah.
There's also a lot of the answers for the what do we write on our requisitions? So that we went through that, how to fill out the requisition, and the instructions are in that kit that you're going to get. Do we perform the same test as cytology? Yeah, the test, the way you do the cervical sample is exactly the same as what you've been doing. You put the speculum in, you visualize the cervix, you either use the broom or use the spatula and the endo brush, you swish it into the thin prep bottle, you tighten the lid. It's exactly the same.
But you take it out, but you take the brush or broom out. That's
don't
different.
leave anything in the
That's
bottom.
important. Please take it out. Please take it out.
Yes, exactly. The kits should have been the labs have been delivering these kits. So if you don't have your kits, your thin prep bottles and your brooms or your spatulas and brushes, call your lab person and have them bring it to you. And they should be bringing you the this folder as well with everything in it. Okay, because the labs have this information and they have the kits. All right.
There's a question here. Any
yeah.
tests available for males? And the answer is no, not at this time. Question about commenting on screening for DES daughters. Do you want to talk about that briefly?
So thankfully, DS daughters are very, very rare at this point. I have only one in my practice, and she's almost done with her screening. So it's not a patient population you're going to see very often. With the DS daughters, I see her in colposcopy, and I have a look at her cervix. So they can get different abnormalities of the cervix that aren't necessarily HPV related. So these are probably better followed by a gynecologist or a colposcopist. They certainly can have their routine screening because, of course, they can get HPV as well. But again, thankfully, we're not seeing too many of those patients anymore. I have a question here. During this transition period from old to new cervical cancer screening guidelines, will healthy patients with previously normal PAPs be eligible for OHIP covered HPV cytology screening in 3 years, or will they have to wait 5? No, you can bring these patients back at their 3-year interval. So again, screen the patients when they are supposed to be screened. Okay.
Will the government still be keeping track of those who are due for pap from cytology and from HPV, especially this overlap period of few years?
Sorry, what was the question?
In this overlap time period now, with some people are due based on cytology results and then HPV. So is the government going to keep track of who's due for what? And I think the answer is you're going to get your result from your previous cytology. That's going to end as of March 5th. So anyone who's there, you sort of continue on what their recommendation was from that, and then you just start doing HPV from there. So there's going to be a period of time there where you're going to have to sort of integrate what your previous recommendation was. Or as you can say from some of the answers here, if you wanted to lengthen it out based on the fact of very low risk, you could do that. But you want to get an HPV done when the timeline is appropriate for it. But you're probably not going to get a government to integrate the two, cytology and HPV, from the past cytology. That's not going to happen right now.
And they also want to know who the immunocompromised population is, and this population will change, right? You can have a patient who's not immunocompromised and becomes immunocompromised. So those they won't be getting letters every 3 years because the program won't know who they are. Yes, the recommendations for next steps will be on the lab reports. Okay.
50-year-old with hysterectomy 10 years ago for a fibroid, no cervix. Does she need an HPV test now? That's the vaginal vault testing, yes, we're talking about.
Hysterectomy, sorry.
10 years ago due to a fibroid, so not HPV, no cervix.
No, she does not need vaginal vault testing. What
The
about
bottom.
older women with cervical cancer? So cervical cancer should be followed, anybody who's been treated should be followed either in a cancer center or with, they don't get cervical screening. They won't get a vaginal vault test if they've had a hysterectomy or radiation, because this test is not useful in this patient population. So they need to be screened with a physical examination, pelvic examination. When you repeat due to unsatisfactory cytology, do you repeat the HPV test or do a PAP? So I think that there is a box on the requisition.
There's a box. The bottom box on the bottom box in the requisition
Bottom box,
says
I don't know
cytology
if you
only.
can see it there. So that's cytology only. So they've had an HPV positive with unsatisfactory cytology. Okay. But it's the same test you're doing on them. You still need to use the broom or the spatula, and you know. Can people eventually clear HPV in time but still have DNA damage and get cancer later? They need to have an active, persistent HPV infection in order to get cervical cancer. So if they've cleared their HPV infection, they should not get the disease.
So it's always a case of one of. So Deborah said a patient with abnormal cytology HSIL, 2 negative HPV, she went for colposcopy and was treated for HSIL. So how do you explain that? Is the
So
question.
there is an there is a false negative rate of any test, and the HPV test isn't perfect. But it's a low false negative rate. So you're always going to have those one-off patients, right? You're always going to have, I mean, I've seen them in my practice too, where they've been HPV negative, but they have high-grade cytology. And, you know, what we need to remember is the PAP test or the cytology test is not a perfect test as well. So you may have had a patient who had a normal cytology test, and in people who actually have cervical cancer, 50% of those cytology tests are going to be normal. So the PAP is not a perfect test either, and some of those patients would also have been missed. So we have to understand that no test is perfect, and it is possible we are going to, some patients are going to fall through the cracks like they do with any test that we do.
Well, it's after 7:30. That really wasn't how I wanted to end it off with that particular answer. That's the wrong message entirely. But I think what we've learned here today is that we have a test that's actually going to look at the infection. We have some rules to follow, but the rules are going to be laid out for us in the result letters. There is a transition period that is going to be a little bit tougher in terms of figuring that out. And feel free to ask if you have a situation like that. That's what Cancer Care Ontario team is there for you as well. You can reach out to myself or to Felice as well. These are situations that are going to be a little tough, but for the most part, there is an algorithm that lays it all out for you. And the slides that have been shown, it's been taped and it's available to you, so you can go back and look at those. But if you follow the algorithms, you're going to get to the answer for just about everything. So this is going to be available to you to have a look at. So hopefully that's going to make it easier for you down the road. Last words to you, Dr. Lackman. Thank you for the excellent presentation.
Thank you. And thank you all for coming and taking the time. I'm always available for questions. I'm always available for referrals of colposcopy. And please reach out if you need anything.
And one of the mechanisms you can reach out is with e-consults as well. So if you have a case you're not sure about, I mean, of course, you can try to send one of us an email, but another way of doing this is sending it through e-consult. And there are some people that are going to answer those questions through that way as well. So maybe another mechanism to get an answer a little bit quicker. So good luck to all of you as we navigate through this change. But I think in 2 years when we have a conversation about this again, you're going to be happy you made the change. Your patients, more importantly, are going to be happier as well. We're going to find disease earlier and be able to help people. So have a good night, everyone. Thank you to Rakaya for organizing everything, and stay out of trouble, guys.
Thank you both.
Have a great night, guys.
Good night. Thank you. Bye.
Thanks,
Bye all.
Alan.